Hello, my dear friend. Welcome all of you in this doubt solving session of PSM. My name is Ashwani Ranjan. I have done my MBBS from Aligarh Muslim University and my MD in PSM from AIIMS New Delhi. So in this session, I already received some query from my dear friends. So we will discuss in this session about community trial, randomized control trial, three type of cohort study, what are the differences between them, then some other miscellaneous question from measles, rubella vaccine and prevalence of disease. Okay, and you can also post your doubt in the chat box. So first is, how does the prevalence of disease decreases? Prevalence is something which is incidence into duration, simple formula, and therefore if we have any disease whose duration is very small, or if we have a new treatment which is decreasing the duration of disease, then prevalence will decrease. Okay, or suppose we are using some preventive method or some vaccination by which we are decreasing incidence, then also prevalence can decrease. Okay, so prevalence of disease decreases by actually three methods. First is when we have some, like for example, when we are using mask, or when we are let's say having community exercise program. So these community exercise program or mask or social distancing, these type of thing, or vaccination, this type of thing will decrease the incidence and therefore prevalence will decrease. Or let's say, suppose we found some new treatment for HIV or hypertension which can decrease the duration of disease, so then the prevalence will decrease. Okay, so remember this, that if a new drug treat disease quickly, then prevalence will decrease. If a new drug treat disease quickly, okay, in this case the prevalence will decrease. Now because in this case the drug will lower the duration of disease, so the prevalence will decrease. Okay, so these are the four methods which can decrease it. Now what is cohort study? It can be of three type, and it's very simple to understand. One cohort is where outcome has not happened, outcome not yet happened. For example, suppose you want to know the effect of alcohol drinking on number of fight or number of accident. So if you are doing a cohort, it means you will start with one group who are exposed, one group who are drunk driver, and one group who are non-exposed, those who are non-alcoholic driver. Okay, so you will start with alcoholic driver and non-alcoholic driver. These are the two groups of cohort with which we start, and then at the end we will see how many accidents occur in which group, number of accident here and number of accident here. After doing follow up for, let's say, 1 year, you can find that in which group the accident will be more. So this is a simple type of cohort in which accident is the outcome which has not yet found. Outcome has not happened. We start with there and then we go to forward direction. So this is one type of cohort. The second type of cohort is known as retrospective cohort. In retrospective cohort, we start from present moment, but the outcome has already happened. The result has already come. Okay, so this is the main difference between these two type of cohort. Outcome already happened. For example, let's say you want to know in your college that whether the staff who are working in radiological department, whether they have more cancer cases or the one who are working in other departments like simple pediatrics, medicine, surgery. So you can take a data of past, let's say 20-year work record data you can take, and from that 20-year work record data you can find that the staff who are working in radiological department, let's say, have 1.4 times more risk of having cancers than the staff working in other department. Okay, so they should get some extra salary or some more better medical insurance, and they should get more care, regular checkup. Okay, so past 20-year work data record shows radiological staff or radiological department staff has 1.4 times more prevalence. Okay, so as compared to other departments. So in retrospective cohort, the cancer has already happened and you are using past record to prove that it is more in those who are working in radiological department. Okay, now the third type of cohort is mixture of retrospective and prospective cohort. If you mix both the component, then it will be formed as the third type of cohort, that is mixed cohort. And in mixed cohort also, same as retrospective cohort, outcome has already happened. Okay, outcome already present. But this time you are collecting the past data as well as you will follow them in the future. For example, a very good example is in your Park textbook latest edition, that there was a study by Doll and Brown scientist. He found that there were around 13,000 patients, and these who were getting the radiation therapy for ankylosing spondylitis. Okay, so this 13,000 patients were getting radiological therapy, and at that time it was not proven that radiation therapy can lead to leukemia. So they found that these 13,000 patients who were on radiation therapy for last some duration of time, last 5 years, have more leukemia cases as compared to the other group who are not getting radiation therapy for ankylosing spondylitis, have around 1.7 times more leukemia cases as compared to other patients, without radiological exposure history. Okay, so this is again something which has already happened. Outcome is already present. Some patient has already developed leukemia from radiation therapy. Now when they found it out, then they started a cohort study and they followed this group in future for, let's say, 5 more years. So they found past record data of 5 years and they followed in future for 5 years. That means they are having both the component simple cohort and they are using past 5-year data. So that is retrospective cohort. Okay, so who were radiation therapy for last 5 years have 1.7 times more leukemia cases as compared to other patient who did not get radiation therapy. Okay, and please remember that in this mixed cohort we have also this future component. Okay, so they are followed for, let's say, 6 years in future, and when they followed in future they also find that again leukemia cases are more coming in those patients who receive radiation therapy. Okay, so this is 3 type of cohort. Remember one very simple and important thing, that in the normal cohort outcome is not yet happened, but in mixed cohort and retrospective cohort outcome has already been happened. Okay, if you are just going in the past, it means past means retrospective, so that is retrospective cohort. But if you are going in the past and in the future, that is mixed cohort. So we can call mixed cohort as prospective plus retrospective cohort. Now in exam they can also ask you various names of these study. Like mixed cohort can also be called as prospective plus retrospective cohort. It can also be called as ambispective cohort because there is both the direction. The movement can occur in forward direction as a normal cohort and in the backward also. So the ambispective cohort. And one more name they gave to it is nested case control. Now why they call it nested case control? Because we are mainly doing 6-year follow-up in future. This is our main study which is happening. And in this 6-year future study, we also inserted data of past 5 years. So this last 5-year data coming from record is the case control part. This case control is inserted in cohort. कोहॉर्ट स्टडी 6 साल के लिए जो हो रही है उसके अंदर 5 साल के डेटा को घुसा दिया गया है ना, घोंसला बना लिया उसने, है ना, दैट इज नेस्टेड, इंसर्टेड. सो दैट इज नेस्टेड केस कंट्रोल, एम्बिस्पेक्टिव, prospective plus retrospective cohort or mixed cohort. So these are the 4 names here. Now in this part where we are calling retrospective cohort, we are just using the data of the past. So it is retrospective cohort, or there is one more name to it, historical cohort, because we are just taking history here, historical cohort. These are the 2 names of this study. And why, how it is different from case control? In case control, we ask history from the people. Like if you want to know whether throat cancer occurred due to BD smoking, okay? So you can take some people with throat cancers, some people without throat cancer, and you ask the history. Did you smoke BD in the past 10 year or 20 year or not? So that is case control. You are asking history from people. And in case control, there can be recall bias. One group can forget the history, other group will remember. But here we are not asking anything from anyone. We are just using the past data. So it is historical or retrospective cohort. Now, what are the name of a simple cohort? This simple cohort study where outcome not happened, disease not happened, is known by many other name. First simple name of cohort study is longitudinal, because we are following 2 group longitudinally. One who drink and drive, one who are non-alcoholic and they are driving. Okay, so we are following them in future. So that is longitudinal study. And because we are following them in future, so we can call it follow-up study. And because we are going in future, so we can call it as prospective study. Okay, and future can also be called as forward, so it is forward study. So these 3 names, follow up, prospective, forward, is very simple to understand. They are the same word. They are talking about the future. Now, when will you have your new girlfriend, or when will you have your new boyfriend? In future or in past? Of course, it can either occur in present moment or it can occur in future. Past में तो X थी, है ना, past was X, gone, है ना, forget her, forget him. So that's how we can only find new cases from future. So we call it incidence study. It cannot be found in case control, है ना, because we are in past only X, now future incidence. And here we don't have the outcome. We start with exposure and go to outcome. Exposure can also be called as risk factor. Like drink and drive is a risk factor. So we can call it risk factor to disease. And the last name we can give it to is alcoholic driving was the cause which lead to the effect of accident. So one more name we can give it, cause to effect. So these are the 9 names we can give to cohort study. These were the 4 names to mixed cohort and 2 names to retrospective cohort, retrospective or historical cohort. Okay, so I hope you will remember these 9 names, these 4 names, and those 2 names with this example which we discussed. Okay, if anybody have any confusion here, you can ask it in the group. So this was one question. Now, Bhargav Patel has a question before moving ahead. He wants to know about reorder factor, lead time and procurement with example. So let's take this hotted debate topic of reorder factor. See, it's a very simple thing. For every month, this reorder factor is equal to two into n, where n is the number of month. Okay, so if you want to know the reorder factor for, let's say, factor for 3 months, you want to know. So reorder factor for 3 months means it will be simple 2 into 3, it will be 6. If you want to know reorder factor for 1 month, it will be simply 1 into 2, so it will be 2. So this is the simple way to find reorder factor. And why we need reorder factor? Because if we have to write down the order of, if we have to place some order for the drug, okay, so we have to find number of drug placed or written in order, how many drug you want to demand. Okay, so if you want to know how much drug you want to order, you just have to know monthly consumption of that drug, and you have to know the reorder factor. If you know these two things, reorder factor and monthly consumption, you can easily find the drug which you want to place into the order. For example, in INICET, they ask this question that there are 20 patients on amlodipine per month, amlodipine, and they are taking amlodipine OD once a day. Okay, so there are 20 patients on amlodipine HS once a day, and 10 patients on lisinopril came from some other center. So 10 patients on lisinopril again once a day. So how much drug will you order for 1 month, and what is the reorder factor? Okay, so to know these two things, we just have to know average monthly consumption and reorder factor. This is the simple formula, and they are talking about 1 month. So the reorder factor for 1 month, we just have written that for any month we have to know 2 into n. So for 1 month, reorder factor is 2 for 1 month, and this is the reorder factor. And monthly consumption of drug, if you want to know, 20 patient plus 10 patient, because all of them are taking once a day. Tablet amlodipine is also before sleeping once a day, and lisinopril also 1 a day. So tablet is once a day, and there are total 30 patient. Okay, so 30 patient are taking once a day tablet, so they are taking it for, let's say, 30 days, and that is once a day. Suppose it's a monthly, so 30 into 30 will be 900. Actually, this dose of drug, the number of patient was 40 and 10 in the real question, 40 plus 10, so 50. But anyway, let's take it 30 patient who are taking it once tablet a day for 30 days. So the amount we need is 900, and if you multiply it by 2, you will get the number of drug to be placed in order. So how much order you will place? 900 into 2, 1800. Simple. And what is the reorder factor? 2, because it is for 1 month. If suppose there is not 20 patient, 40 patient, then again 40 plus 10, 50 patient, 50 into 30 for the drug, because everyone need 1 tablet a day in this story. So 50 into 30 plus 50 into 30 into reorder factor. So 50 into 30 is 1500 into reorder factor, that is 2. So it will come 3000. The original answer in the question of INICET was 3000 and reorder factor was 2 because it is for 1 month. So this is the simple formula. You just want to know this basic thing. If you know, you can solve this type of question. But if you want to understand this full concept, what is this lead time, what is procurement level, then we can learn that also. See, first thing is we have to know what is our minimum level of stock. Okay, how much minimum drug we need. So this minimum level of drug which we need is defined as basically safety stock, which we also called as buffer stock, safety or buffer stock you can say. So buffer stock plus lead time stock. And what is this lead time stock? Whenever we place order, the order do not come in within 1 day. Suppose we placed it today, so it takes around 7 days to get the order. So at that time, some stock will be used. So that is lead time stock. Lead time stock is usually for 1 week. And buffer stock also we keep for 1 week. So minimum level of drug which we need is usually for 2 weeks. For 2 week dose we minimum need at any time in our pharmacy. We need drug for at least 2 weeks any time. Okay. Now this is, we can plot also in graph like form and understand it in a better way, that this is the 1 week of buffer stock. Okay. And suppose this is the stock amount of drug which you have at any amount of drug is like this. Suppose here is the amount of drug. So when the amount of drug touches this minimum level, then you have to place the order. You cannot go below minimum level. So it will touch, suppose here, the amount of drug decreases and it reaches here. Now we are plotting time here. So when it reached minimum level, we placed order that okay, now we need refill of this pharmacy store. And suppose it take this time. This is the duration of time which it is taking for order to receive. So here we placed order and this is the time where we received order. And the time gap between placing order and receiving order is known as lead time. Lead time का सीधा मतलब है कि हमने जो ऑर्डर प्लेस किया और आने में 1 हफ्ते का समय लगेगा, तो वो 1 हफ्ते का समय लीड टाइम है. और उस टाइम में जो स्टॉक यूज हो रहा है, ये जो स्टॉक यूज हो रहा है, इसी को कहोगे लीड टाइम स्टॉक. ये वाला अमाउंट ऑफ ड्रग यूज हो रहा है. वी आर यूजिंग दिस मच अमाउंट ऑफ ड्रग which is around 1 week. So we put 1 week of buffer stock, 1 week of lead time stock, and if you add 1 week plus 1 week, it will become minimum level of stock. Okay, and this is the amount of drug at which we order. So we call it as the amount of drug where we are placing order. So we can call it as reorder level. This placed order is reorder level. We order from here. Okay, and this is minimum level of drug which is 2 weeks, but the average amount of drug which we need, average amount of drug needed is equal to twice the minimum level. Okay, so the minimum level which we have find is 2 weeks. So that means we need, at any time we need, average amount of drug we need for use is of 4 week duration. So for 4 week duration, we should have the average amount of drug needed. Okay. Now, this minimum level of stock is the time where you have to place reorder. So this is the reorder level, minimum level of drug. And for 4 week we need, the average amount of drug is around 4 week for 4 week duration. So whenever we are placing order, we are writing amount to be placed as equal to monthly consumption into reorder factor. है ना, this is the original formula, and reorder factor is 2 into n, because you can see here that this is the average amount of drug which we need at any time. For 4 weeks we need at any time, and monthly consumption for 1 month is suppose coming 900. This is the monthly consumption of tablet. So we need double of that. We need one thing which is being used monthly, and we need one thing which is needed at any time. So by this way also we can understand reorder factor. Okay, so these are the 4 concepts in reorder factor and reorder level. First thing is reorder factor and reorder level. These two are different things. Reorder factor means 2 into n. This is reorder factor, and reorder level is minimum level of drug, minimum safety stock, or minimum level of stock, minimum level of drug that is there, is the reorder level. When the amount of drug reaches the minimum level, then we place order. We place order at reorder level. Okay, so this is reorder level where we are placing drug, and reorder factor is simply 2 into n, where n is the number of month, we multiply it by 2 and we get the reorder factor. Okay, so please understand and remember this simple formula. Number of drug we are placing order is monthly consumption into 2 into n. For how many months we are writing? Reorder factor means simple 2n. Okay, sure. Now let's go to the second doubt which you have already posted in the group. Okay, Amal Roy has a question, sir. Difference between buffer stock and lead time stock. The difference is that buffer stock is that stock where we never reach. This is the minimum stock which is always maintained. But lead time stock is that stock which is consumed between placing order and receiving of order. Okay, so definition wise these are different. Okay, if you want, I can write down these two difference to further clarify your concept. Buffer stock is the least amount of drug which is never touched. In theory, we never consume buffer stock. Okay, which is never given or never used, which should never be used. Okay, so we always maintain the buffer stock. And what is lead time stock? I was saying lead time stock is amount of drug distributed between placing order and receiving it. Okay, you place an order and you receive it. It takes around 1 week time to place and receive the order, and buffer stock is also 1 week time. So when you add these two definition or these two things, after adding lead time stock plus buffer stock, we get the minimum stock at which you have to place the order. So minimum stock is that stock at which order is placed. Okay, so this is the difference. I hope, my dear friend, it is clear. Now good evening MBBS Khan, good evening bhai. So I hope Amal Roy, it is clear. Let me know. Now let's get first to the question which we are already posted in the group, in the WhatsApp group, and after answering that will take only 5-10 minutes. Then I will answer the doubts posted in your YouTube group. Okay, now after discussing the 3 type of cohort study, the next question was, what is RCT? So RCT is an interventional study where you give something from your side. You give a new drug or you practiced a new method on some patient. आपने कुछ कीड़ा किया, कुछ उंगली किया, है ना? So RCT is an interventional study. First thing. where we do or give something. The next question in the group is what is community trial? So we will understand these two very easily together. We can do some new intervention at 3 levels. One thing is I can give some new drug or medicine to you people, the healthy people. So if I am doing interventional study on healthy people, healthy population, we call it field trial. Because healthy people are in the field. है ना, ऐसा नहीं है कि वो वहाँ मैदान कर रहे हैं, झाड़ा फिर रहे हैं, ऐसा नहीं है. They are in the field. They are found playing football and other hanky panky doing that's thing. So they are field trial. If I am doing it on patient are found in clinics, hospital. So we call it as clinical trial. And if we are doing on people of the whole village and compare it from nearby village, or of the whole country and compare it with the nearby country, we call it community trial because it is done on community. Let me give you one more example of community trial. We all are wearing masks sometime nowadays. And when the wave is not there, still some of us are wearing it. So in Bangladesh, they did a study guided by UNICEF and WHO that is this mask actually protect us from COVID or not? Because it has not been proven anywhere. We just wear it because in 1918 flu we did it, and then during COVID China and UK did it, so we just followed it. So whether mask actually protect from COVID or not. So to know this thing, they divided 6 villages into group of 2 villages. First 2 villages, they gave the normal surgical mask to wear. Second 2 villages, they gave cloth mask. And third 2 villages, they gave no mask. And they tried to know that between these 3 type of villages, which villages will have more COVID cases. Okay. So what do you expect? This is community trial. You understand the model, na? We are comparing 3 group of 2 villages, one with cloth mask, one with surgical, one without. What would be the result? Of course, we think result will be cloth will have less cases, surgical mask will have less. But actually the result came all village have same prevalence of COVID. There is no significant difference. There is some difference in cases, but almost same. And it was because the study was done when there was no wave of corona. For example, right now there is no wave of corona. So if you wear mask or you don't, it doesn't matter right now. So if I do a study right now between people in your college, let's say in Maulana Azad Medical College and Safdarjung Medical College, I did 2 college study. One student I forcefully asked them to wear mask, one I do not allow them to wear mask, and then compared it. Right now there will be no difference because there is no wave. So the same case occurred in that trial also. Okay, there was no difference because there was no case. And if we are comparing students of Maulana Azad Medical College with a student of Safdarjung Medical College, not pairing, comparing. Okay, so if I am comparing them, then it is a type of community trial because we are comparing one community of a whole medical college with the other community of other medical college. Okay, so this is community trial. The main thing, most important thing in RCT is we don't select participant of the 2 group. Suppose you found a new drug to treat obesity for people like me. You are doing some favor for me. So suppose there are 200 healthy people who came for your study. You will put chit on the table and you will ask them to choose from A and from this chit. Those who choose, suppose chit A will go to group A. Those who choose chit B will go to group B. Okay, this is a simple example how we can do randomization. Okay, but many a time we simply randomly allocate them into 2 groups. So RCT means they themselves get divided into 2 groups. I am not selecting them that who will go into my drug group for obesity and who will go in the placebo group. They themselves are divided randomly on a lottery method. So this is the most important characteristic of RCT, that people are randomly divided. Now RCT can be of 2 types, parallel RCT and crossover RCT. When we talk about parallel RCT, we simply just follow the two group of people. For example, there is one RCT being done by Baba Ramdev where they gave coronil to one group of drug, one group of person, and placebo to other. और कोरोनिल के साथ एक और काम किया, तेल डाला कहाँ पर, है ना, नोज, nasal oil drop he used in one group and not in another. So in this coronil study, again these two groups are randomly selected, and then they followed them at 3-day and 7-day, and when they followed them at 7-day, they found that in the coronil group there was 0 positive, but in the placebo group there was 20 positive, because of course they were getting coronil, so they have to become COVID negative. So these are randomly selected COVID positive, RT-PCR positive, and asymptomatic patient who don't had fever or anything. Okay, just came COVID positive, but they were mostly asymptomatic patient, and they were randomly allocated into the two group. They went by the lottery method, A and B. So this is simple parallel RCT where we are comparing it. Now suppose we have some study in which we are comparing a new drug amphetamine with a placebo, and I want to know that amphetamine will increase IQ or not. So I will give, let's say, amphetamine to group A and placebo to group B. Now, they are allocated in two group by randomly. There were 200 people who were randomly allocated into two group. Now, after following them up for 3 months, I measured their IQ. And then after giving amphetamine in one group, placebo in another group, I did nothing for suppose next 6 months. So this period where we do not give any drug, we just observe the people, that is known as washout time. So this is washout time for, let's say, 6 months. And then in the group A, I gave placebo, and in group B, I gave amphetamine. So here what we are doing is we are doing crossover. We are crossing the treatment of amphetamine from this group to, we are first giving amphetamine in group A, and now we are giving amphetamine in group B. And here we were giving placebo in group B, we gave it to group A. So we are crossing over the treatment. After giving a washout time, we are crossing over the treatment, and then again following them up to compare their IQ, and again follow up for 3 months. So this type of RCT is crossover, where we are crossing the treatment, and coronal RCT was parallel. Okay. So these were the two type of RCT. These are the 3 type of RCT, out of which field trial is on healthy people, patient clinical trial, and community is community trial. Okay. I hope it is clear. If you need more example, please let me know. Now, next question is on rubella and MMR vaccines. So in India, we have 2 type of vaccine. One is MR and one is MMR. And there are 3 important questions which come from here. First is this MR and MMR vaccine, which we give at 9 months and 16 to 24 months. This is our routine immunization program in which we are giving measles rubella vaccine. And our target is that in routine immunization program, at least 95% children should get the vaccination. Because if 95% are vaccinated, remaining 5% will be protected by herd immunity, because all around these 95% are vaccinated, all 100% will be protected. Okay. Who will save the remaining 5%? They will be saved by 5%. 5% will be saved by herd immunity. You know now what is herd immunity? Herd immunity simply means, suppose these are the people who are vaccinated. Okay, these are vaccinated people for corona, or vaccinated not for corona, but suppose they are vaccinated for measles and rubella. And in between them, there is one person who is unvaccinated. Now, suppose an unvaccinated person came from some other country, let's say Afghanistan they came, and now they cannot spread the infection to our person, because this our friend is protected by these all people who are having the herd immunity, who are giving him the herd immunity. So this is our target, 95%, so that we can protect all the children of India. So this is known as keep up strategy. Keep up strategy means keep up the good work. Give 95% people vaccination in routine immunization. Okay, this is the keep up strategy. Now, after keep up, the second strategy is catch up. Catch up means all the children who are between 9 months to 15 years, they should get vaccine in one round. In all the area where measles cases are high, we are trying to give vaccine to 9 months to 15-year children once every 10 years. Why we are doing it? When 100% are protected by keep up and 95% by vaccination, 5% by herd, why we need catch up? Because this is an ideal condition, 95% vaccination rate. In India, measles immunization rate is around 75 to 80% in reality. So 25% children are still unvaccinated for measles, and if you give vaccine of measles to 100%, it will not protect 100%. Some more people will not be able to, not 100% will be able to develop immunity. So roughly you can say that by this routine immunization, you can say that 70% are protected. Our target is to protect 95, but 70% are protected. So for the remaining 30%, we are doing catch up. 9 month to 15-year children receive MR vaccine once every 10 years. Okay, we prefer MR in this vaccination campaign, but if MR is not available, then we can use MMR. The last strategy is follow up. Okay, follow up means we are giving catch up measles rubella vaccine every 10 years only, and there will be many children who are born in between that 10 years. So by follow up, we will give vaccine to those children who are born between this 10-year duration. So follow up means after every 2-3 years, all children between the same age group, 9 months to 15 years, will receive again the same MR vaccine. And this is something which is again done in those areas where measles cases rate are high and where measles cases are coming high. So what we do in catch up, once every 10 years we give vaccine to all children. Follow up means every 2-3 years we are giving vaccination to all the children between 9 months to 15 years, and these are those children who are born after catch up program. Suppose you did catch up program in this year, suppose you went to Bihar, Chhattisgarh, and you did this catch up program in 2022. So in 2023, all the children who will take birth, they should get follow-up vaccine every 2-3 years till you reach 2032. Then you will have second catch-up campaign. So catch-up campaign occur once every 10 years, give vaccine to 9 months to 15 years, follow-up every 2-3 years, again the same age group, 9 months to 15 years. So these are the 3 strategies: keep up, catch up, follow up, which will make India measles rubella free. Okay, this is our target. to achieve this elimination of measles and rubella. We have already discussed community trial. Now, let's see the question in your YouTube group. I saw one question very early about sampling technique. Deepak Saini has a question. COVID vaccine in pregnancy is contraindicated or not? So, according to the new guideline, COVID vaccine can be given in pregnancy also, but not in first trimester. Okay, so very good question. COVID-19 vaccine is now can be given in pregnancy, but this is government guideline. For exam, you have to say that it can be given, but for practical purpose, I think we should avoid COVID-19 vaccination in pregnancy because it might have some long-term effect. Suppose like there is a drug diethylestesbesterol. This diethylestesbesterol, this drug is given in pregnancy, and suppose I am the pregnant female who received diethylestesbesterol and I gave birth to a girl child. Okay, you imagined me as pregnant female. So I am giving birth to a girl child. Now my girl child will develop adenocarcinoma of vagina 18 to 20 year after the delivery. Okay, so it is given in pregnancy, and female girl child develop vaginal adenocarcinoma. So sometime we don't know that what is the side effect which will occur, especially for vaccination. We are not sure, and right now there is no wave of COVID also being there, so we can wait, let the pregnancy happen, then give it practically. But theoretically government is approving it because of course it is profitable for the government. Okay, so they approve it, but we should not give it right now because there is no way practically. Now one question was very early, sir Hindi में भी बताइएगा. Deepak Pandre, whatever you do not understand in English, please let me know. I will translate it in Hindi and I will tell in both the language. है ना, दोनों लैंग्वेज में बात कर लेंगे. आप बताना कोई भी डिफिकल्टी लगे तो प्लीज बताना, हिचकिचाना मत. चलो आगे बढ़ते हैं. एक क्वेश्चन है साइनिंग स्टार का बहुत पहले ही कि सर प्लीज डिस्कस डेटा सैम्पलिंग मेथड ऑफ स्ट्रैटिफाइड एंड सिस्टमैटिक रैंडम सैम्पलिंग. वेरी गुड. व्हाई नॉट साइनिंग स्टार? See, these two methods which you said to compare, they both are method of random sampling. In random sampling technique, if we are following a fixed pattern, suppose every first and fourth house is selected for an interview or for an study. So if you are selecting every first and fourth house is selected for interview in a study, you are following a fixed pattern of choosing nth person. This is known as systematic random sampling. है ना, आप यहाँ पे एक सिस्टम फॉलो कर रहे हो कि हर पहले और चौथे को चुनेंगे या हर 9वें बच्चे को चुनेंगे. ओके, तो ये हो गया सिस्टमैटिक रैंडम सैम्पलिंग. अब सिस्टम तो है कि चौथे और पहले को चुनेंगे. रैंडम यहां पर क्या है, ये जो नंबर आया ना पहला और चौथा, ये रैंडमली आ गया. दिस फर्स्ट एंड फोर्थ डिजिट, इट इज टेकन रैंडमली आउट ऑफ 10 एंड इट केम फर्स्ट एंड फोर्थ. सो इट इज सिस्टमैटिक रैंडम सैम्पलिंग. ओके, नाउ स्ट्रैटिफाइड रैंडम मीन्स first we will divide the village, let's say between slum area of the village and the other area. We will divide the village first. So this is stratified random sampling, where we are, suppose you want to know the vaccination rate in a village, but you want to know that in the village how much is the vaccination rate in the slum area of the village, because in most of the villages of India we have Harijan Mohalla, Harjan Mohalla is that area of the village where people from oppressed community are forced to live together, है ना. तो उस हरजन मोहल्ले में या स्लम एरिया में कितने बच्चे वैक्सीनेटेड हैं एज कंपेयर टू अदर पार्ट कितने बच्चे वैक्सीनेटेड हैं. सो हियर व्हाट यू आर डूइंग इट फॉर स्ट्रेटिफाइड रैंडम सैम्पलिंग इज you are dividing a population into two or more subgroup, okay, and then you are choosing equal number from each subgroup. Suppose for this study you selected, let's say, 20 children from slum area and 20 children from normal area of the village. Okay, this is 20 children of slum area and 20 children of normal area, and you ask it from their mother that had they received measles vaccination or not. So you will find most probably that in slum area the measles immunization prevalence is, let's say, 75%, whereas in normal area it is, let's say, 95 or 90%. Okay, measles vaccination you can ask. So this way you are dividing the population and choosing equal number from both the group. So this is stratified, because strata means layer. Strata का मतलब ही हुआ कि आपने कुछ डिवीजन किया, है ना, आपने लेयर क्रिएट किया, स्ट्रैटा लेयर. सो वी आर क्रिएटिंग द लेयर एंड चूजिंग इक्वल नंबर फ्रॉम बोथ द लेयर, एंड वी आर चूजिंग दीज पीपल रैंडमली. हाउ दीज 20 चिल्ड्रन आर सेलेक्टेड? देयर कैन बी 50 चिल्ड्रन इन नॉर्मल एरिया, 50 इन स्लम एरिया. सो दिस 20 आर सेलेक्टेड रैंडमली, बट फर्स्ट वी डिड द स्ट्रैटिफिकेशन. फर्स्ट वी डिवाइडेड द पॉपुलेशन, then we choose randomly. So this is stratified random sampling. Remember one very important question, that stratified random sampling is best for heterogeneous population. Heterogeneous population is that population which is different from each other according to question. Here the question was how many are immunized. तो ये दोनों ग्रुप अलग अलग हैं इम्यूनाइजेशन रेट में ना, तो ये कैसे होगा? हेट्रोजेनस, एक दूसरे से अलग, बिकॉज दीज टू ग्रुप हैव डिफरेंट इम्यूनाइजेशन रेट. सो दिस इज अ सिंपल एग्जांपल ऑफ हेट्रोजेनस पॉपुलेशन. सिमिलरली, सपोज यू वांट टू नो, you want to compare smoking rate in Mumbai with smoking rate in Delhi, and you want to compare the smoking rate in medical college student of Mumbai and medical college student of Delhi, कि कौन ज़्यादा फूक रहा है. तो आप अगर मुंबई गए, मुंबई मेडिकल कॉलेज गए मान लो, और आपके पास ज़्यादा टाइम नहीं है, यू डोंट हैव मच टाइम, you selected 10 student randomly, and you went to the class representative, ask him list of the students, and you randomly tick any 10 student, they can be girl, they can be boy, and you selected them. So if this 10 students selected randomly from Mumbai, and in Delhi also you selected 10 students randomly for this study. Okay, now I have let's say, suppose in Mumbai, suppose boys are smoking more than girl. I'm not saying it is like that, but suppose boys are smoking more than girl, and if you got 8 boy and 2 girl here, so the result will come that Mumbai, the smoking is very high, smoking rate high, because you are getting 8 boy, and suppose out of 8, let's say 6 are smoker. Okay, and in Delhi, although I know the smoking rate is almost equal, but suppose here also boys are smoking more than girl, suppose, and here you got, let's say 7 girls and 3 boy. So here also girl is smoking less. So here when you are taking 8 boy, you are getting 6 smoker, and here when you choose 7 girl, you found only 3 smoker here and 2 smoker here. So here total are 5 out of 10, and here total is 6 plus 1 7. So you can think that in Mumbai the smoking is more because it is 6 plus 1 7 smoker in Mumbai out of 10. 70% are smoking in Mumbai, and in Delhi only 50% are smoking, 5 out of 10. Okay, so why you get this wrong data? Because you selected the student randomly. We select them randomly when they are homogeneous population, when they are similar to each other, then we do simple random sampling. But in this example you can see boys and girls are different from each other in smoking in both the metropolitan cities. Suppose boys are smoking more than girl, so we can get wrong idea by choosing random sample. That's why when the people are different from each other, we prefer stratified random sampling. Okay, because if you are doing stratified random sampling, then you go to Mumbai and you will take 5 boy 5 girl. You go to Delhi and you will choose 5 boy 5 girl. You first divided the student into boys and girl and then select 5 5 from both. So this is a type of stratified random sampling. And if you have 5 boy 5 girl in both the sides, then the data will be right, and then you cannot say that in our sample more boys were there, so smoking was high, because now boys and girls are equal. So please remember this point, that we do simple random sampling for homogeneous population. जब भी लोग एक दूसरे के जैसे होते हैं तब हम करते हैं सिंपल रैंडम सैम्पलिंग. सपोज आई वांट टू नो how much marks you will get. So for marks, boys and girls are same, and boys can be smart, girls can be smart, and they both can get good marks. Suppose, so if I have some question where you are same, homogeneous means same according to question. According to question you are same. Okay, so in this case we will do simple random sampling, but if you are different according to question, we will do stratified random sampling, where we will divide the population and then choose equal number from both. So stratified random sampling is for heterogeneous population which are different according to question. Okay, which are different population according to question. For example, for vaccination, normal village is different from slum area village, and for smoking, boys are different than girls. So in those cases of smoking and village vaccination, we should do stratified random sampling. And for if we are comparing boys and girls for marks, or if we want to take 5 boy and 5 girl for party, so for party we can take boy or girl, anyone. So we are taking boys and girls for party. These are simple. We can do simple random sampling and I can choose any 10. Okay, but if they are different, we will do stratified random sampling. Okay, chalo. Now let's see some more doubt if you have. Amal Roy is saying that, sir, there is a separate syndromic management kit for inguinal bubo and genital ulcer. So if a patient present with both genital ulcer, non-herpetic plus inguinal bubo, then which kit is given? See, this last kit, you are writing non-herpetic genital ulcer in the question. So this non-herpetic genital ulcer is treated by 2 kit. One is white, other is blue. Okay, I hope you remember the syndromic management. The first is the gray. First category is gray, and gray is used for 4 things: urethral discharge, cervical discharge, prostatic inflammation, and anorectal discharge. So gray is the most common color of the people, most common first category. Then you have green for vaginitis, and after green you have white and blue for non-herpetic ulcer, and red for herpetic ulcer. So it's very simple to remember. Remember, gray is most common color of people. Then we have GG, gray, and then green. And this you can remember by the mnemonic WBR. Like WBC, it is WBR. All three are for genital ulcer. So the point is, when we give white category, we are giving penicillin. And when we give blue category, we are giving doxycycline. And this doxycycline is given 100 milligram twice a day. This is a capsule doxy, 100 milligram twice a day. And for genital ulcer, usually the duration that they keep is maximum around 14 days. Okay, they start with 7 days, so they can go to 7 to 14 days. So this is WBR. Then we have the 6th category, yellow. Yellow is for PID, backache and lower abdominal pain. Okay, and then we have the black inguinal bubo. So what is the treatment which we give under black category inguinal bubo? Here also we are giving capsule doxycycline, the same thing, capsule doxycycline. But this time we are giving 100 mg BD for a more longer duration, 21 day. Because bubo means lymph node inflammation. So there is lymph node inflammation. We need a longer duration treatment. So we are giving here for 21 day. So if a patient came with non-herpetic genital ulcer and inguinal bubo, we can simply give doxycycline for 21 day, twice a day. Because anyway we were giving doxycycline for non-herpetic ulcer also and inguinal bubo also. So because the treatment is same in both the category, we just need to give doxycycline for the one which is maximum duration 21 day. But suppose you ask, a patient has herpetic ulcer and inguinal bubo. Then in herpetic ulcer, we give tablet acyclovir 800 mg 3 times a day for 5 days. So if he have herpetic ulcer and inguinal bubo, we will combine acyclovir and doxy give and give the treatment to the patient. And if we have non-herpetic genital ulcer and inguinal bubo, we will simply give doxycycline for 21 days, 100 mg twice a day. Okay. Very good question, Amol, because here the drug is common, so we will give the same treatment for 21. Otherwise, we can add them. Okay. Thank you, Signing Star. Thank you. Sir, Ganesh Rai is saying, sir, please discuss COVID-19 vaccination schedule. How to immunize a person against COVID if he is recently infected by novel COVID virus. Thanks in advance. Arey, Ganesh, you need not to thank, dear. Simple thing is that we just find out if there is history of COVID infection in last 3 months. So if there is history in last 3 months, then we try to not give the vaccine. So the second vaccination or the vaccination will be done vaccination after 120 day or after 3 months of recovering from COVID. Okay. So when you recover from COVID, you wait for 120 days and then take the next COVID vaccination. Other than that, in the guideline, they have said that if you had any severe life-threatening allergy from previous dose, you will not take it. Okay. So these are the two things they say regarding COVID vaccination. 120-day gap after recovering, plus not take if there is life-threatening side effect. You were about to die. Life-threatening side effect in last dose. Okay, in previous dose. So that's all from the question that you have posted in the group. Thank you so much. Amal Roy, Ganesh Roy, signing star for asking the question. Ganesh Roy saying it is the immunity of the community that will stop the transmission and it break the transmission cycle. Yes, Ganesh Roy, that is herd immunity. Very correct. Okay, and then COVID vaccination is not contraindicated. Amal Roy is also asking difference between field trial and community trial. Very good question, Amal Roy. See, we already discussed that in RCT it can be field trial, clinical trial, or community trial. So when we do field trial, we are recruiting person. Suppose you are doing a trial for a new obesity drug. So you have the new drug here, or you are doing a trial of a new anti-anxiety drug. You want to make people happy with a drug which is having least side effect. So you have new drug X and you are giving placebo to some other people. So here are 100 people and here are 100 anxious person who are normal in the field, normal present but anxious. They are not coming to OPD but they are anxious. So this is a simple field trial. Suppose you are, or let's say you are simply, so here we are comparing patients from each other. But when we do community trial, we are recruiting whole village. Suppose after your MBBS, you went into your district area or your state, rural area, and you want to develop your state. So for a community trial, from your district where you live, from the district, you take randomly any 3 village where you did some intervention. You started self-help group of people where people can meet together, they can arrange some money with each other, and they can start some local business. So this is self-help group which will help each other, have monthly meeting. And this self-help group intervention you did in 3 villages which were selected randomly. And then from the same district, you selected other 3 villages where you did not did anything. So these 3 villages are control. You are just allowing them to grow normally by the government program. So you randomly choose these 3 villages and compare with these 3 villages. And suppose you found that in your 3 villages, after 1 year, the bank balance is more, people are more employed. So you can then increase this model of self-help group to the whole country level by giving suggestion to the government. So here you are comparing 3 villages of your district randomly selected from other 3 villages of your district. So this is community trial, you are selecting village, but in field trial, you will recruit patient randomly, you will recruit normal people, or you will recruit people from the field one by one. Okay, so here people are recruited in field trial, and in community trial, whole village, whole community is recruited. Okay, so that's the difference. Thank you very much for asking question. Hello Mulai Vendan. Hello Ganesh Roy. Thank you so much, dear friends, for being here. I think I have discussed all the doubt that you said. If there is any doubt, feel free to ask it from me on my WhatsApp number. And you can also send a mail to me. So this is my WhatsApp number 8860796675, and this is my email ID docashwani23@gmail.com. Please remember, this is DOC, not DOG. Okay. Chalo. So thank you very much for being in this session. Keep enjoying your life. Hasta la vista. Das vidania. Bye bye. Thank you so much. Bye bye.